Candidate 1, you can see the image.
I can.
Okay, this is your first case, and this is just 1 second. Let me tell you the history. 24-year-old male hindfoot pain. Over to you.
Thank you. I'm presented with AP and lateral radiographs of a skeletally mature adult who's a 24-year-old presenting with hindfoot pain.
Yes.
Yeah. I cannot see any obvious fracture. There is an area of sclerosis, density, just distal to the tibia in the region of the medial talus. Although I cannot see a definite fracture. The talar dome, while smooth, I can see that the margin between the talus and the distal tibia and fibula is uneven, raising a suspicion of a potential dislocation. I cannot see any lytic lesions in the distal tibia or fibula. The partially visualized distal metatarsals look unremarkable. In conclusion, there is an increased density sclerosis of the medial aspect of the talus. I can also note a similar sort of sclerosis and added density outlining the margin of the calcaneus laterally. There is also a significant soft tissue swelling adjacent to the calcaneus in that region. I would relay my findings to the clinicians and correlate my findings with the clinical history. I suspect this patient will require cross-sectional imaging in the form of a non-contrast CT to characterize these findings further.
Right. What do you think is this?
This looks like a spur just of the anterior talus.
Right. And please remember, there is no history of any trauma.
Mm-hmm.
Second thing is that this view is not optimal. It is slightly tilted. Now, the main emphasis is on this finding. What do you think is happening here?
It looks like the anterior aspect of the talus. It's not as smoothly contoured as I would expect it. It's almost like a spur.
Yeah. So do you expect that in a 24-year-old?
No. It looks more like a bony outgrowth.
Right. So what comes to your mind regarding cause of this?
Potentially, it could be a variant, but this patient's symptomatic, so I'm inclined to include things like the potential that there is no real periosteal reaction to this. It's just a bony outgrowth, so it could be a benign entity.
Young age group, what comes to your mind?
I'm not sure at this point.
Okay. I'm going to show you an MR of the same patient. Can you scroll through this?
I'll just request.
Yeah.
Okay, I've just requested it. Okay, yeah, I'm able to scroll through the images. So I'm presented with MRI of the foot and ankle in sagittal T1. The previously seen abnormality on the radiograph is again demonstrated in the anterior aspect of the talus. The marrow returns a different signal when compared to the rest of the talus. It's low in T1 with an outline of lower signal.
So this is a PD weighted sequence. Please continue.
Sorry. I cannot see any kind of soft tissue component adjacent to this bony outgrowth.
Concentrate on any other finding which explains the finding which you have picked up on the talus.
On review of the remainder of the study, I can see the joint space between the talus and the tibia is preserved. The calcaneum is unremarkable. The talonavicular joint space is also preserved. The subcutaneous tissues also look normal. So I'm just having a look at the heel and the muscular components, again, unremarkable. So
okay, look at the calcaneonavicular joint.
Calcaneonavicular. Okay. So I can see, I would expect a joint space. It looks like there is a combination, a coalition between the calcaneus and the navicular bone.
What kind of coalition is this?
Calcaneonavicular coalition. Right.
And pathologically speaking, how many types of coalitions are there?
So there is I know of two. Remember, there's a talonavicular.
My question is slightly different.
Yeah.
There is coalition between the two bones, and what can be the bridging material between two bones?
Bone or cartilage.
Right. What will you do next?
I would relay my findings to the clinicians and recommend an orthopedic review. We've, having already done plain films and an MRI, I think that they should be referred to orthopedic specialist opinion.
Okay, thank you. Please don't use the mouse. Now I'm taking over. So this is talonavicular coalition. Now, few points to remember. Coalitions in the foot are extremely important exam scenario. And there can be many types, but the most important are, 90% of them are either talonavicular or talocalcaneal. Talonavicular or talocalcaneal. 45% each. So 90% of these are out of 100. Rest are very rare. So if they show you, they will show you either of these. They will always start with plain films. And on plain films, the key point to remember is that the concept of which views are important. Now, one key point to remember is that on the lateral X-ray, may it be of foot or may it be of ankle, there are always secondary effects at the talus. And this is the key finding which you have to pick up. This is because of mechanical strain here. So when the coalition is around this, there is abnormal motion at this joint, and this is a sort of a degenerative type of change, like an osteophyte. So you have to pick this up. We call it talar beaking. Once you pick up talar beaking, then you have to have clear-cut concept that what kind of collation will be visible on which view, plane films, and this is where they are going to start. So, key point is that for calcaneo-navicular collation, oblique foot X-ray is the best. For talocalcaneal collation, axial view is the best view. Of course, some of the findings can be seen when in talocalcaneal collation on lateral view also, particularly if it is a bony type. There are three types of collation, pathologically speaking: bony collation, cartilaginous, and fibrous. In bony collation, the bone marrow will merge. In cartilaginous, there will be a sort of a pseudo joint. On MR, it will be slightly high signal, telling you that this is cartilage. And fibrous collation will be low signal on all sequences on MR. So, CT scan or MR scan, you don't have to worry about it if it is cartilaginous or fibrous. You just look at the, subarticular irregularity or sclerosis or any edema, depending on if you are seeing a CT or an MR. So coming back, let me show you a few cases to take this concept further. So this is a X-ray of a 9-year-old with talar beaking here and nil talar beaking on the other side. Please remember, collations are 50% bilateral. 50% is a huge number, and this is a classical VIVA question. So when they ask you, what will you do? You should actually yourself volunteer that I will advise imaging of the other joint. Many a times it is symptomatic, asymptomatic. So you have to advise the other joints. That's a VIVA scenario. Now on this, when we see oblique view, this is an example of calcaneo-navicular collation. But this one is not bony collation. If you look carefully, this is the normal side. This is the joint space between the navicular and the calcaneum. And look here, there is a bit of irregularity, a bit of, marginal irregularity, and the joint space is not as well defined as this one. So this is a collation, maybe cartilaginous or fibrous, whatever. So this is calcaneo-navicular collation, and the key point to remember is best seen on an oblique film of the foot. Another case. In this case, if you see, this is a 13-year-old male, and we can see talar beaking here. And is there talar beaking? Maybe, but not very, obvious. This is the left side where there is talar beaking. Now, the best view to diagnose talocalcaneal collation is an axial view, unless it is a very gross bony collation, which can also be seen on lateral view, which I'll show you. Now, this is the key joint, and you have to have a clear-cut concept about the anatomy. This axial view is usually not performed, and unless there is a suspected fracture of calcaneum. So the key anatomy is this one. If you see here, calcaneum and talus, there is a what we call subtalar joint. And calcaneum has got three facets: anterior facet, middle facet, posterior facet, which is the largest. This one, the middle facet, is sitting on this bone, which is known as sustentaculum tali. So this is posterior facet, this is middle, and this is anterior. Collation is most most common at the middle facet. And anatomy-wise, on an axial, this is the sustentaculum tali. So this is the middle, talocalcaneal joint. And this is now, if you look carefully, you will see that there is a bit of sclerosis irregularity as compared to this. So another talocalcaneal collation, it is not bony, and there might be fibrous component or cartilaginous component here. Another case which is a gross case because it's a bony. Here, you can develop your eyes on another sign. This is the talar beaking, but look at this. This is known as C sign, and it gives you the appearance of a C. Together, there is a projection of the bony sustentaculum tali as well as the posterior portion of the talus. Gives you the C sign. So you have to develop your eyes on this sign. And this is the CT scan of the same patient, which tells you that at the middle facet, there is a collation here. This is a bony collation. Another case where we can see talar beaking, we can see this C sign, and on MR, we can see this bony collation, talocalcanea. On a CT scan, just to see the anatomy, if you see here, we are coming from posterior. This is left and this is the right ankle. This is the fibula, this is the tibia. So the posterior most facet, this is the posterior facet, which is the largest facet. In this case, there is some abnormality here. You can see that the joint space is reduced. And as we come anteriorly, look at the middle facet. Again, a lot of sclerosis and the joint space is reduced. It is not a complete bony collation, but definitely marginal sclerosis, etc. is there. So anterior facet is normal. So this is an example of CT scan where middle as well as posterior facet was involved. So it's a very important case, and you have to remember that in a young age group, you keep it in your mind. Candidate 1.
Yep, still here.
Okay, so just 1 second. Let me give you the sequence which I want to show you. Just 1 second. So this is a 53-year-old female, recurrent bilateral neck swellings, oral thrush. Over to you.
Thank you. Just requesting control. Just scrolling, yeah, thank you. So I'm presented with axial MRI of the skull base and neck in fat-saturated T2 sequence. I'm just going to scroll through the images in the given set before I comment. Sorry, of an adult patient presenting with recurrent neck swellings.
Bilateral.
Bilateral neck swellings, okay. So on first review, I've not spotted an immediate abnormality. So I'm just going to go through my review areas, starting with the skull base. The partially visualized brain parenchyma appears to return normal signals with no significant intracranial mass. The maxillary sinuses look clear. I'm just going to review the symptomatic region of the neck now. I cannot see any abnormality in the submandibular region or floor of mouth. I'm just going to carefully assess the neck region.
Please look at the parotid glands.
Yeah. On review of the parotid glands, I can see multiple foci of high signal in symmetrically enlarged glands.
To remember that in a young feather, there is a projection of the bony sustentaculum tali as well as the posterior portion of the talus. Gives you the C sign. So you have to develop your eyes on this sign. And this is the CT scan of the same patient, which tells you that at the middle facet, there is a collation here. This is a bony collation. Another case where we can see talar beaking, we can see this C sign, and on MR, we can see this bony collation, talocalcanea. On a CT scan, just to see the anatomy, if you see here, we are coming from posterior. This is left and this is the right ankle. This is the fibula, this is the tibia. So the posterior most facet, this is the posterior facet, which is the largest facet. In this case, there is some abnormality here. You can see that the joint space is reduced. And as we come anteriorly, look at the middle facet. Again, a lot of sclerosis and the joint space is reduced. It is not a complete bony collation, but definitely marginal sclerosis, etc. is there. So anterior facet is normal. So this is an example of CT scan where middle as well as posterior facet was involved. So it's a very important case, and you have to remember that in a young age group, you keep it in your mind. Candidate 1.
Yeah, still here.
Okay, so just 1 second. Let me give you the sequence which I want to show you. Just 1 second. So this is a 53-year-old female, recurrent bilateral neck swellings, oral thrush. Over to you.
Thank you. Just requesting control. Just scrolling, yeah, thank you. So I'm presented with axial MRI of the skull base and neck in fat-saturated T2 sequence. I'm just going to scroll through the images in the given set before I comment. Sorry, of an adult patient presenting with recurrent neck swellings.
Bilateral.
Bilateral neck swellings, okay. So on first review, I've not spotted an immediate abnormality. So I'm just going to go through my review areas, starting with the skull base. The partially visualized brain parenchyma appears to return normal signals with no significant intracranial mass. The maxillary sinuses look clear. I'm just going to review the symptomatic region of the neck now. I cannot see any abnormality in the submandibular region or floor of mouth. I'm just going to carefully assess the neck region.
Please look at the parotid glands.
Yeah. on review of the parotid glands, I can see multiple foci of high signal in symmetrically enlarged glands. I cannot see any extraglandular invasion of the surrounding soft tissues or subcutaneous tissue. I'm just reviewing to see if there are any enlarged lymphadenopathy. That's, in my usual practice, I would look at the orthogonal planes to assess.
Just 1 second. I'll give you another sequence. Here you are.
Thank you. So I'm presented with coronal of the same sequence.
Just look at the parotids.
Yeah. So again, the parotids look bilaterally enlarged, and I'm just trying to locate the parotid duct, and I think the parotid duct on the left side looks dilated.
Where is it?
Sorry. I'm looking at this area here.
Right. So, what do you think is happening within the gland? You know, you could see these punctate high signal intensity foci. What exactly is that?
So it could represent an inflammatory process if it's bilateral. It could potentially be secondary to a ductal calculus. Although I was trying to search for any low signal foci within the ducts, but I couldn't delineate that. It could be.
Where does the parotid duct open?
Where?
Does the main parotid duct open in the mouth?
I'm not sure.
Right. So what is your conclusion?
So my conclusion is bilateral parotid gland enlargement with innumerable high signal foci. This could represent an inflammatory / infective process, or it could be a malignant process. Just trying to think, it's not pleomorphic.
Okay, thank you. Case 2 is bilateral parotid sialectasis, means duct dilatation, and this is a case of Sjogren's syndrome. So in your book, diffuse parotid enlargement. Diffuse parotid enlargement can be unilateral or bilateral. Please remember, our case is bilateral, and very few things will cause that. Of course, parotitis like mumps, etc. can cause it, but nobody will image a case of mumps. Bilateral stones, etc. is quite a rare entity. Unilateral stones and sialadenitis, etc. of course can happen. But here, this is important. These two are, and maybe sarcoidosis also, but in Sjogren's syndrome, what happens is that these patients have got a dry mouth, dry eyes, and dry skin, and there are multiple other stigmata. this is connective tissue disorder, and Sjogren's syndromes can be associated with scleroderma, with rheumatoid arthritis or SLE, etc. Now, you have to remember this. This is extremely important, in your long cases, in your, VIVA cases, etc. These things are critical, which are asked for, particularly in long cases. They might give you this MRI, and with that, something in the hands. And the conclusion or the unifying diagnosis will be that this is RA, which is causing Sjogren's syndrome. Basically, pathologically speaking, what happens is that the parenchyma, there is destruction of the parenchyma, and there is dilatation of the intraparotid ducts. And this presents as these punctate, small cavities, and there are various grades which I am going to show you. Please also remember that there can be also deposition of lymphoid aggregates, and you have to rule that out because that will be what we call soft tissue nodules. Now, this is the parotid gland, left and right, and though it is not visible on this MR, but the main parotid duct, it goes like this and opens into the cheek, and this is a conventional parotogram, scialogram, which shows you that the duct is in the cheek, lateral aspect, and this is how it is. The submandibular scialogram will be in this axis because the submandibular gland is at the floor of the tongue, the opening, I mean to say. Now, these are the ducts. These are the intraparenchymal ducts, and basically in sialactasis, because surrounding architecture is destroyed, these ducts, they dilate. And this is known as sialactasis. If you do conventional scialograms, then sialactasis is actually graded, but you don't have to remember this grade, but you should remember that in punctate sialactasis, these are usually less than 1 millimeter, globular 1 to 2 millimeter, cavitatory more than 2 millimeter, and complete destruction of parenchyma, where you might find cystic change, etc. Now, this is another case, which is CT scan, and which is more gross, and you can see this destructive parenchyma with cystic dilatation, a bit of calcification bilateral. Another case where you can see these ducts which are dilated, and with that, in this particular case, actually there is a nodule here, which enhances. This is a fat saturated T1 weighted sequence. The key sequences in head and neck are STIR. So this is not a T2 fat sat. By definition, STIR is a T2 fat sat, but physics is slightly different. So this is one of the standard sequence in soft tissue neck, STIR sequence. With that, a T1, and then T1 fat sat and T1 post-contrast fat sat. These are the key sequences. You have to differentiate it with benign lymphoepithelial hyperplasia of HIV, and this is also here in your book, Chapman. Benign lymphoepithelial lesions of HIV mimic Sjogren, but other glands are spared. Look for adenoidal hypertrophy and reactive adenopathy of HIV. Please remember, these patients, this is a benign condition in which there are multiple cysts in the parotid gland. There can be cyst in the submandibular glands also. With that, you will see lot of neck nodes. You will see adenoid hyperplasia, and this is a classical picture of HIV, benign lymphoepithelial hyperplasia. And please remember that this, the word benign means there is no malignant potential for this. You have to know this. And please remember again, long cases, etc., can be given. You might get this in your exam, and with that, a lymphoma of the brain, primary lymphoma. So you have to know that this happens in HIV. Thank you, candidate 1. Candidate 2, are you with us?
Yes, sir.
Candidate 2, this is a 32-year-old female, leg weakness, bladder dysfunction. Unfortunately, the patient was slightly claustrophobic and we could acquire only 3 sagittal sequences, but I believe you will be able to make your diagnosis on the sagittal. Over to you.
Okay.
Can you ask for
Hello,
the mouse?
can I be heard?
I
No,
can hear you. Please ask for mouse. You know how to ask for the mouse? Candidate 2, can you hear me?
Yes, I can hear you now.
Right. Do you know how to ask for the mouse?
Please, can you scroll for me?
Okay. So,
Thank you. Hello?
yes.
Can I be? Okay. Sorry.
We keep losing you. I cannot hear you.
Of the dura sac with posterior scalloping of the visualized S1 and vertebra.
You know what happens is
bodies.
that I can barely hear a few words and then I cannot hear you. Please, say again whatever you have said. Say again in one go.
Okay. So I've been presented with sagittal T2 weighted MRI sequence of the lumbosacral spine, and on the first look, and I appreciate that there is an enlargement of the dura sac, with a lobulated convex outline anteriorly, which is scalloping the posterior aspect of the visualized vertebral bodies, the lumbar as well as the upper sacral bodies. There is no, there are some kind of modic changes of the upper part of the visualized vertebral bodies. There is no obvious mass within the theca sac or anterior or posterior to the vertebral bodies. No epidural collection seen. There is normal alignment of the vertebral bodies. So I'll be thinking of neurofibromatosis, neurofibromatosis type 1, which usually gives this duraectasia, which is a neurocutaneous disorder. And with that, I'll inform the referring physician of my findings and review previous images if available. I also recommend referral of this patient to neurosurgical team for further management.
So why to the neurosurgical team? What will they do?
For further imaging, to look other sequences and reconstruction, to look out for if there is a lateral meningocele, if there are neurofibromas, and if there are for surgical resection of these tumors. Also for the brain to see if there is any CNS brain affectation as well.
Okay, so
there is need for screening as well. Sorry.
The patient is symptomatic. I told you it's a 38-year-old leg weakness, bladder dysfunction. Why is the patient symptomatic? What do you see on this scan which can explain the symptoms?
Okay, tetraene of the cord.
Say again?
Tetraene of the...
Tethering of the cord. And what do you mean by that?
The lower spinal cord is plastered posteriorly to the posterior spinal element, making it less flexible, and which can be the cause of the neurological symptoms like urinary bladder incontinence. Sorry, I couldn't hear you earlier. I couldn't hear the history because of network.
Right, I'm showing you a T1 weighted sequence. Do you see anything to explain the tethering of the cord?
Okay, looking at for lesions. I'm sorry.
Here I am pointing out. What do you think is this?
Is high intensity on T1. I'm not certain what it is. But it could be high intensity on T1 could suggest blood, fat, or protein, and in this case, since it's linear, I'll be thinking of fat or hemorrhage.
Okay, now coming back to the first sequence which I showed you, you said there is cord tethering. And what does it mean? What is the location of the normal conus?
Okay, L1, L2 vertebral body. L1, L2 vertebral body. L1 first / second lumbar vertebral body. That is at the lower part of the L1 or upper part of L2. The normal position of the conus medullaris. So
give me your conclusion.
I'll be thinking of neurofibromatosis with tethered cord, sir.
Okay. Now, there is tethered cord with lipoma of phylum terminale, which is the cause, and then there is, of course, dural ectasia. We'll come back to the case. Now, in your Chapman, there is a differential diagnosis: intraspinal masses, extradural, intradural, intramedullary mass or swelling, and then there are lesions related to cauda equina, and one of them is phylum terminale lipoma. fatty thickening of the phylum plus minus cord tethering. Please remember that lipoma of the phylum terminale is a common normal variant. It might not cause cord tethering, it might not cause symptoms. But when it causes symptoms, the patient can be extremely symptomatic. They might come in teenage, early 20s or early 30s with a lot of symptoms. So the conus normally is located between T12, mid portion of T12 till upper portion of L3. But most commonly, it is somewhere between T12 and L1. If the conus is distally located, then this is what cord tethering is. In cord tethering, it is not plastered to the posterior elements. It is actually pulled downwards. So please remember that. And so there is a bit of traction on it, traction and pull. And the concept is that because of that, there can be ischemia, a bit of ischemia of the cord, and at times, and because of that, patient will be extremely symptomatic. Cord tethering is a potential surgical case, and surgical case means that you have to refer to the neurosurgeons and they treat it. They will remove that, the connection with that lipoma, and the patient will become better. Second thing in this case, which candidate 2 did well, was the stigmata of dural ectasia. So another thing which I could have asked was the differential diagnosis of posterior scalloping of vertebral body, neurofibromatosis in which there can be dural ectasia. And one of the key things in neural fibromatosis is that whenever you, in the exam, you say you will advise MR of whole of the neural axis with contrast. Remember that. You must do that. Whole of the neural axis with contrast. They might show you or they might not show you, so that you pick up any tumors, both in the spine as well as in the brain. Now, please remember that in neurofibromatosis, the dural ectasia is without associated tumor, or there can be associated tumor. So the same finding, posterior scalloping, can be associated with a tumor or without a tumor. And there are other things like tumor in the spinal canal, which can cause posterior scalloping. Posterior scalloping of the vertebral body is a very important exam case. Remember that, per se. But in this case, what I showed you, there were two findings. Tumor in the spinal canal is the most common, then neurofibromatosis, then acromegaly, achondroplasia. These ones you must remember. So this is a case of NF1 with dural ectasia and long segment instrumentation, correcting the scoliosis. And again, you can see this posterior scalloping and widening of the foramen. These are three different cases, and if you can see, these are from Radiopedia, that this is posterior scalloping, similar or slightly more marked than the case which I showed you. This is because of dural ectasia, but this one is because of a tumor. The tumor is sitting here and is causing scalloping. On the CT, there is scalloping. Incidental scalloping here in the thoracic region. On MR also, you can see it. This is a case of intraspinal tumor, one of my favorite cases, in which, if you look carefully, this is a classical exam case. And on this AP film, what is happening, that if you see, these are pedicles. So the pedicles are flattened. Something is sitting in between these. This is flattened, this is flattened. So there is a differential diagnosis in Chapman, widened interpedicular distance. So from here to here, this is increased, and here it becomes better. Here it becomes absolutely normal. So there is a long segment tumor sitting there. And on the lateral of this, you can again see posterior scalloping. Now, if you look at the pedicles are not visualized. And here the pedicle is visualized, here the pedicle is visualized, here they are not visualized. Why are they not visualized? Because they are eroded, they are compressed, they are thin. And because of this, the X-ray beam sort of passes through them, giving you this false impression as if they are absent. Actually, they are thin. So this is intraspinal tumor. Now, this is an MR of a different case. This is not the same case. I do not have a MR of this case, but this is a different case from my collection where you can see what happens. This is a myxopapillary ependymoma of the phylum terminale, and here you can see a bit of on a T2 weighted sequence. You can see hemosiderin, which is low signal, and you can see how it causes posterior scalloping. And on the post contrast, there is a bit of enhancement. Now concentrate on this axial, and here you will understand what happens, because look at this pedicle, and the tumor is all, this is the tumor, and the pedicle is thin. And this is what was visible on the previous X-ray. So the current case, here, so the feedback on the case is that if you see here, there is posterior scalloping, and then you can see this cord tethering. Where is the conus? And you struggle to see. This is L5, this is L4. Where is the conus? You ask yourself, and it appears somewhere here, definitely L4 or L5. So that means that there is cord tethering. And then cause of the cord tethering. If you go to the T1 weighted sequence, you can see this is the lipoma, and you have to ask for neurosurgical referral, and they will simply, make this connection will be, sort of cut off, and the patient will become sort of asymptomatic. So that was your first case. This is a 76-year-old male. This patient had some surgery with the urologist, and this is a 1-year follow-up scan. Over to you.
Okay. Please can you help me scroll? I've been presented with
you have to ask for the mouse. Do you know how to ask for the mouse?
Yes, but I'm using a phone, so I can't scroll with the phone.
If you are using phone, you will not be able to do it. You should not be using a phone if you want to be a candidate and you want to scroll. Do you know how to ask for the mouse? No.
I think I do.
So ask, if you ask, then it will pop up on my screen and I'll give you the permission. Okay, now, so in future, any candidate who wants to present, you should know how to ask for the mouse. And there is no concept of being a candidate and being on your phone. You should be on your laptop or iPad, etc. Now, so let me scroll it for you.
Okay, sir. Thank you, sir. Okay, so I've been presented with abdominopelvic CT scan of a patient who had a urologic surgery, And this is the 1 year follow-up, um, 1 year follow-up image. On the first look, okay, I can appreciate that there is a mass within the lumen. I can appreciate that there are surgical clips in the pelvis, likely sites of the operation, and I really couldn't see the urinary bladder. Maybe I need to look at it well again. Okay, so I couldn't really appreciate the urinary bladder in the pelvis, and there are lots of surgical clips denoting the urology surgery, and there is a anterior abdominal defect seen on the right abdominal quadrant, likely with bowel loops connecting into it, so likely a hernia, and there are atherosclerotic changes within the abdominal aorta, as well as the lumbar vertebrae.
Okay, excuse me, because you are not able to scroll, I'll guide you. Look at this ureter where I am pointing out. Keep looking at the ureter.
Okay.
What is happening?
Is as if there is a fistulous connection between the ureter and a branch of the aorta, likely the common iliac artery.
Okay, look at the left-sided ureter, the other ureter. I am scrolling it. Just concentrate on the ureter. So I'll come back to the hilum and just concentrate on the ureter.
All right. Okay, the lower abdomen, the ureter appeared to deviate towards the right. Towards the right,
so what has happened?
With such deviation, if it was medially, I would think of if it was medially, I would think of retroperitoneal fibrosis. But if it's lateral, I'll be worried about a mass in the retroperitoneum. But I can't see any obvious mass there. So the deviation could be iatrogenic. And then there are multiple hypodense lesions in the liver, likely metastasis, as well as a lesion in the stomach, which is also likely with likely cascation, soft tissue lesion within the stomach with cascation, which is likely another lesion, metastatic deposit within the stomach.
This is the metastasis. You feel this is a metastasis?
Is well defined. So
what can it be? Give me the differential for this.
If it is growing esophageally, I would think of GIST, but it's growing within the lumen, so I would think of an adenocarcinoma of the stomach.
If it is what?
If it is growing esophageally outside the lumen of the stomach, I would think of gastrointestinal stroma tumors. But since it's growing within the lumen of the stomach, I'm thinking of adenocarcinoma of the stomach.
You mean to say GIST cannot grow in the lumen?
Yes.
Okay.
If it is growing esophageally, sir.
Okay. This thing, you said that these lesions are metastases, and can they be anything else?
Yes, they can be hepatic cyst or
Okay. Your
hemangioma.
conclusion, just give me your conclusion.
Okay. In conclusion, I'm thinking of uh, a concurrent tumor within the stomach, as well as deposits deposit within the liver, and an anterior abdominal wall defect.
Okay, thank you.
Okay. Thank you.
Now, this patient is what we call, post-radical proctocystectomy with ileal conduit. The patient basically has got a urinary bladder carcinoma. They have removed the urinary bladder. They have removed the prostate because that was also involved. And they have produced for the ureters, they have produced a ileal conduit. And stomach gist is an incidentaloma. Now, this picture tells you that what is an ileal conduit. So what they do is they have removed the bladder, and these ureters, now these ureters, they ultimately are connected with a loop of ileum, and they take out a stoma. So part of the urine goes out here. And please remember that the connection with the rest of the bowel also continues. So part of the feces goes through the normal channel. And there are some variations, but you have to remember this ileal conduit. In the exam, it is a very common thing that the examiner will tell you that the patient had a procedure or a surgery, and you have to then make 2 plus 2 what's happening. And now, as far as gastric masses or filling defect, GIST is one of them. Please remember that it can be endophytic or exophytic. So this concept that if it goes in, it cannot be GIST, you have to, remember this. It can be within the lumen, it can be exophytic also. And it can have necrotic center, and etc., etc. And studies have told us that more than 5 centimeter, there are chances of malignancy. Now, this is another case in which this filling defect actually is a GIST on a, single contrast barium fill. And on a CT scan, this is what it is with oral contrast. And this is an exophytic type of GIST, this one, where if you see this is a huge lesion, actually the stomach itself is this, and this is an exophytic lesion which has got necrotic center. And this case, by the way, it was malignant, and later on it perforated, and the patient died because of that. So this is an exophytic GIST with central necrosis. The same case here. You can see this is the stomach and this is the exophytic lesion. Now, let me take you through the case. Now, the first of all, part of the case was to see what has happened. Now, this is the right ureter where my mouse is. You can see, just trace the right ureter. And where does it go? It goes superiorly here. And then you lose it in this loop of ileum. And this loop then goes out. So this is the ileal conduit. Other side. Now, this is the left ureter. And it is collapsed here, and then it crosses the midline. Here you are. This thin line is it, and it goes into this loop here. And ultimately, of course, this loop continues out. So this is ileal conduit. The candidate did well where the observation was that the bladder is absent, and it was absent, as I've told you. So this case was a satisfaction of search case. First of all, your knowledge that what has happened. It can be a long case. You have to tell in your that this is status post, ureteric diversion, ileal conduit, etc. These are all simple cysts. These are not metastasis. These are, if you have got doubt, you should not jump to conclusion that these are metastasis. You can also say that I can use Hounsfield unit, etc. These are all cystic. But it was a satisfaction of search type of a case where actually there was a second malignancy. There was a CT scan done for this patient 1 year ago, retrospectively speaking. On that one, this was present but smaller and poorly seen because it was, but here it is definitely seen. Okay, candidate 2, thank you very much. Candidate 3, are you with us?
Yes, sir.
"77-year-old female, lower limb weakness, lower limb loss of sensation, bladder and bowel dysfunction." Over to you. You will ask for the mouse, or should I scroll for you?
Oh, okay. I will ask for the mouse.
Yeah.
Request not completed.
The mouse is with you.
Okay, I'm presented with sagittal T2 sequence for lumbosacral spine MRI for a female, adult female with lower limb weakness and bladder dysfunction. In my routine practice, I will go through slices first and then comment. Okay. There is intraspinal soft tissue mason, soft tissue sheets that filling the cecal sac. And I can see that there is a patchy high T2 signal implicating the vertebral body, bone marrow. And then the hemangioma will check through the T1 sequence and see the signal of it later on. I wonder if this soft tissue sheet could be like part of medial metastasis or CSF seedling. I will ask for.
Madam, can you please speak up slightly? Your volume is slightly suboptimal. Can you please speak up?
Sorry, doctor.
Slightly loud. I want you to speak loudly.
Oh, sorry. I'm sorry. Okay. Is it clear?
Yeah, clear.
Okay. I'm suspecting that these soft tissue sheets of seedling, CSF seedling or meningeal metastasis, and I want to see the other neural axis, the brain, check if there is a primary.
First of all, tell me what this is. How will you confirm what your concern is?
I would like to see also the contrast image, the post contrast image, to see if this is soft tissue sheet that filmed.
I've given you a T2 weighted sequence. What are your findings here?
What I see is that the coda equina nerve roots are diffusely are thickened, and I'm suspecting maybe
this is a
of
post contrast.
arytenoiditis.
This I've given you a post contrast, fat saturated T1.
So this defected the soft tissue sheet show poster contrast enhancement. And
conclusion.
Okay, I will ask the patient if she has a constitutional symptoms like fever or something. If it's present, there may be element of arytenoiditis or inflammatory process like meningitis. Okay, I would like to check the neural axis also, if especially the brain, if there's a primary lesion or
this enhancement, what is enhancing?
What is enhancing is the meninges. Now,
meninges.
Yes.
Okay, thank you. Now, this is a special type of lymphoma, which we call lymphomatous meningitis. Nobody is expecting you to say that, but this will be in the differential diagnosis. Please remember that lymphoma can present with intradural lesion, intradural extramedullary, or intramedullary lesion, intradural, extramedullary, and extradural. So, as I told you that I'm not expecting you to say that this is lymphomatous meningitis. You just have to give me a differential diagnosis. Now, in your book, there is this differential 2.17 intra spinal masses. First is extradural masses, then is intradural extramedullary masses, then is intramedullary mass or swelling. And first differential can be metastasis, but please remember that our case, there was, diffuse thickening of the nerve roots. These were not meninges, these were the nerve roots which were thickened. I'll show you. Of course, lymphoma will be in the differential diagnosis. Then sarcoidosis, as I think last time I showed you a case, we call it the greatest mimicker in neuroradiology, sarcoidosis, and that should be in differential diagnosis. Then these things, in the type of findings where the nerve roots are enhancing. This is under lesions related to cauda equina. Guillain-Barré syndrome, where there is smooth enhancement of cauda equina, and there can be thickening of the nerve roots. Then this is a sort of a chronic equivalent of GBS, chronic inflammatory demyelinating polyneuropathy. And then other radiculopathies like, CMV, post-chemo, post-radiation, etc. These words should be in your vocabulary so that you can tell a few of them to the examiner. This is a case of Guillain-Barré syndrome. This is a T1 weighted fat saturated sequence where you can see that whole of the cauda equina, this enhances. Now, if you see the axial, you can see the nerve roots, they are also enhancing. Guillain-Barré syndrome is acute, ascending infection. It goes from down upwards. Another case of Guillain-Barré. Initially, the examiner will show you a T2 weighted sequence, sagittal, where you might or might not see, this thickening of the nerve root. If you see this T2, the first thing which comes through the mind that these nerve roots are thickened, and that's why they are more prominent. When you give contrast, you can see they are enhancing. Sarcoidosis, always remember, in the differential diagnosis, the biggest mimicker in neuroradiology, both in the spine as well as in the brain. Remember that sarcoidosis can cause meningeal, as in leptomeningeal and dura involvement. It can extend into intramedullary part through the the Virchow-Robin spaces, and then it can be extra medullary, as in the bone marrow, etc. So this is sarcoidosis, where you can see a bit of enhancement here, a bit of enhancement here. This is from StatDX, and you can see multiple leptomeningeal pia mater, and look at these nodules sitting on the chorda equina. Another case of sarcoidosis. All of these are enhancing nodules. Now, our case, the key thing was that I showed you initially a T2 weighted sequence. On this T2 weighted sequence, we can see that this is the conus and it ends, and then all of this is abnormal. When we see so actually these are thickened nerve roots. And when we see it on a T2 weighted sequence, you can see how thick these nerve roots are at places. They just occupy all of the thecal sac because they are thickened. And when we give contrast, everything it is on fire. So everything enhances, but if you look individually, actually these are the nerve roots which are enhancing, but because they are jam-packed, they appear as if all of the thecal sac is enhancing. So this was a case of lymphoma, but I am not at all expecting you to call it a lymphoma. You have to give me the differential diagnosis. Okay, next case, please. Madam, this is a 56-year-old female, chronic pain both feet. Over to you.
Okay, I'm presented with X-ray of both foot for adult female, presented with chronic foot
Just
pain.
1 second, please. Let me. Yes, over to you.
So she has only just this foot X-ray, right? Not other.
You cannot ask that question to the examiner.
Okay.
Don't do that in the exam. Just start talking on whatever has been provided, and then you will ask, I want to see that, I want to see that. Over to you.
Okay. I'm presented with X-ray both foot, one other female complaining of chronic foot pain, and I see that there is a bilateral metatarsopharyngeal joint pathological process in the form of erosion, periarticular erosion, and a cortical irregularity. With no intra-articular affection, I wonder if this patient has a gouty arthritis. But I'm searching for if there is associated soft tissue swelling, but it's not evident here. Now I'm searching for the other joints if there is associated abnormality. The main affection of joint and implicating the more the left side and the lateral force for metatarso-pharyngeal joint, and on the right side the affected joint is the right metatarso-pharyngeal fibs, the fibs metatarso-pharyngeal. The distal interpharyngeal joints are spare and not affected. So in conclusion,
Recording in
What
progress.
did you say, gout? What is in favor of, the findings as far as gout is concerned?
in favor of gout, that there is no intra-articular affection, but there is erosion around cortical erosions around the joint.
Which joints?
The metatarso-pharyngeal joint.
Which metatarso-pharyngeal joint? Means it is first, second, third, fourth, fifth.
Mainly of the fourth and the fifth. Yeah, on the right side the fifth. On the left side the lateral from second to fifth.
Okay, what is your differential diagnosis? What else? You've said gout.
Other differential diagnosis.
Yeah. Anything else?
Okay. Maybe psoriasis, but psoriasis there is more affection in intra-articular affection and pencil cupping and more deformation of the joint.
Psoriasis. Psoriasis involves the feet.
Okay, other
from my side. Does it involve the feet usually?
No, it affects more distal interpharyngeal joints.
Okay, thank you, madam. Thank you. Now, this is a very simple case, and last time also I showed you a very simple case, and I told you that how a simple case will become a very difficult case, because this is a case of differential diagnosis, and you should have crystal clear ideas about what are you going to tell the examiner and what it is. This case, the differential, the diagnosis, by the way, is rheumatoid arthritis, foot bilateral, but let's take it further. This is, I think the first slide I forgot to paste, but basically in differential diagnosis case, if you read this one here, what the examiners want to hear and what they do not want to hear. You have to give them differential diagnosis on that particular case. And you cannot regurgitate the whole differential diagnosis case. And if you are challenged, the examiners can ask you even in another context, can it be this, can it be that, can it be malignant? You have to be confident and, stay with your reasonable opinion. And please remember that some of the cases, and it happens, we call them discussion cases. And I could have done that discussion on this particular case for the next, 5-7 minutes. But because of time factor, I did not. The examiners can go on and on and on. And so differential diagnosis cases, you have to really develop your minds on that. Now, as far as arthritis is concerned, this is the overall classification: erosive, productive, mixed erosive and productive, due to biochemical disorders, depositional disease, miscellaneous joint disorders. And out of these, considering, what was happening in this case, there were erosions. Whenever there are erosions, you have to have a clear-cut idea which joints are involved. Digits, and these were metatarsophalangeal joints. And, was the first metatarsophalangeal joint involved or not, things like that. So out of these, 3 arthritis I will keep in overall differential, and, that should be the thought process: rheumatoid arthritis, chronic reactive arthritis, and gout. These are the 3 which one can consider considering the findings here. Please remember that as far as rheumatoid arthritis is concerned, rheumatoid arthritis usually causes what we call bilateral symmetrical changes, which were visible in this particular case. Don't think that the word symmetrical means 100% symmetrical, but there are, overall similar type of findings, right and left. Then comes seronegative arthropathies. In seronegative arthropathies, chronic reactive arthritis is the one which you have to consider, and then there is gout. So another thing, in a case of arthritis, this should be your reflex. If visible on the film or not visible, you have to tell the examiner, I'm looking for periarticular osteopenia, if there is osteopenia or not, call it. Because these arthritis, all of them can cause osteopenia, and or there is no osteopenia. There is preservation of bone density. For example, gout will do that. So this should be your one of the pertinent negatives or positives in a case of arthritis. Now, this is in rheumatoid arthritis, classically, the most common involvement is the 5th metatarsophalangeal joint. And this is an example where we can see this erosion, loss of joint space, and here also there are minor changes at other joints, but the 5th metatarsophalangeal joint is extremely important. This is the distribution. The joints in the red are the most common joints involved in RA. As far as foot is concerned, the 5th metatarsophalangeal joint is the most common. It's not the first, which is in gout. Now, you should have clear-cut concepts of differentiation between psoriatic arthritis and chronic reactive arthritis. And luckily, these things will be repeated in the recording on this weekend. Correction, I think next weekend, not this weekend, next weekend, arthritis. So you can revisit it. Today, I don't have time to tell you everything. But the key thing is that in our case, the foot bones there were erosions in the foot. As far as psoriasis is concerned, the difference, both of these are seronegative arthropathies, psoriasis and chronic reactive. But psoriasis is very rare for involvement of the foot. And if there is foot involvement, usually there is involvement of the calcaneum. It is enthesopathy, which is at the insertion of the Achilles tendon. On the other hand, chronic reactive arthritis, you should have a clear-cut concept that what it is. Previously, we used to call it Reiter syndrome. Now we call it chronic reactive arthritis. Classical clinical presentation was in a male: urethritis, conjunctivitis, and arthritis. So that was Reiter syndrome. Later on, we now call it chronic reactive arthritis. Then we came to know that females can also be involved. Urethritis is replaced by cervicitis in females. Key point to remember is that foot is more common than hand. And this is a case of CRA, chronic reactive arthritis. Key finding, now if you see the fifth metatarsophalangeal joint, there is erosion, there is soft tissue swelling. And look here what's happening. This is enthesopathy at the insertion of tendo Achilles, and this is the hallmark of seronegative arthropathy, which you will not see in RA as in rheumatoid arthritis. So this is CRA. And then comes gout. So as far as gout is concerned, classical, of course, the most common is first metatarsophalangeal joint. And then you go into details of the erosion. There is overhanging margins of the erosions. By the way, the fifth is also involved. Then there is soft tissue thickening. If you see the margins of the erosions, they are sclerotic. And this is said that only in gout you will see it. If you see the bone density, it is preserved. So, so this is, in a differential diagnosis case, what the examiners want, that you have to tell them the differential diagnosis according to age, sex, location, etc. Do not regurgitate the whole of the list. Now, if you go back to your case, there is erosion here, maybe erosion here. And on this side, erosions on both sides of the joint, this one. Now, on the right side, and of course, second metatarsophalangeal is also involved. On left side, these four are involved. Here, this is involved, this is involved. So it was a 56-year-old female. And that age group doesn't go with CRA. It doesn't go with gout for the simple reason that erosions haven't got, the pattern or the joint involvement is not first metatarsophalangeal. The erosions haven't got overhanging edges. The margins of the erosions are not sclerotic. So you are left with rheumatoid arthritis. If the examiner pushes you, you can tell your thinking process that in differential, I can consider CRA. However, this is, not the age group of CRA. And I would like to see, calcaneum, for example, to see any enthesopathy there. This is not gout for the reasons which I have told you. So you have to develop this kind of thought process for your exam. Thank you, candidate 3. Candidate 4, are you with us?
Yes, sir, I'm here.
Okay, candidate 4. 81-year-old female, vague abdominal symptoms including vague pain, flatulence, etc. So they had done CT abdomen and rule out any cause, any obstruction, any diverticulitis. Vague symptoms, vague request. Over to you.
Okay, sir. Okay, I'm trying to scroll. I'm provided with the axial sections of post-contrast images of the abdomen and the pelvis of an 80-year-old female who came with history of vague abdominal pain. I'm scrolling from top to bottom before starting my comments. Okay. On the first scroll, I can see that there are bilateral perirenal hypo to isodense lesions or area C, and these lesions are separately seen from the kidney. However, there is no obvious involvement of the renal parenchyma. I am trying to look for enhancement of these lesions. In my routine practice, I would like to correlate with the pre-contrast images. There are areas of fat within these lesions. I would like to confirm in my routine practice with the HU units of these areas. And trying to look for any other abnormalities. I'm trying to trace the adrenals. Okay, but both adrenals appears normal. I don't see any obvious lesions within. Okay, I'm trying to look the major organs. The liver appears fine. Gallbladder appears fine. Spleen appears fine as well. The stomach collapsed. I don't see any obvious lesion within. So I'm trying to assess what these lesions are. Okay. I'm trying to trace the renal vessels. Renal vessels appear fine. I don't see any obvious filling defect or any aneurysmal dilatations. I'm trying to trace down the ureters for any filling defect or any lesion. Yeah, I don't see any abnormality in the ureter. The urinary bladder appears collapsed, minimally distended. Okay, so to summarize, I see that there are I saw two hypodense lesions or areas in the perinephric region bilaterally involving both renal fossa regions, and these lesions are well maintained in their borders. I don't see any obvious involvement of the adjusted structures. However, there is mild fat stranding surrounding these areas. The renal parenchyma appears normal. There is no obvious evidence of hypodensity within this renal parenchyma. So to conclude, these could be angiomyolipomas or perirenal collections. Also, I'm keeping differential of any other lymphomas. However, the renal parenchyma appears normal. This could also be a spontaneous hemorrhage involving the both kidneys and which is limited by perirenal fascia. In my routine practice, I would like to correlate with the history of any hypotension in this patient.
No history of hypotension.
Okay. I would like to correlate with HU values. If it is around 60, I would be thinking of hemorrhage in this patient.
It was not 60, it was soft tissue.
Okay. So these could be simple cysts as well. However, there are no evidence of any. Okay. The simple cyst doesn't show any fat components. So do I have any other images like delayed and anything? So.
Okay, well done, candidate. You did well. Your description was good. Your thinking process was good. Of course, you had never seen it, so you could not decipher the case, but you did well. Okay, let me take over. Have you ever heard about this candidate 4?
I have heard of the disease, sir, but not in the kidneys.
Okay. Do you know that it is a pathognomic sign? The word pathognomic is a sort of an aunt mini. This is it. End of story. And this is Erdheim-Chester disease, hairy kidneys. So now, what is this is from your second portion of Chapman, page 558, 559. You can also read it from Radiopedia, for example. Erdheim-Chester disease is a rare non-Langerhans cell histiocytosis with multi-system manifestations, often characteristics on imaging. Please remember the second part of Chapman has got a lot of these conditions with multi-system manifestations, sarcoidosis and lymphoma and you name it. So must read it from there. It is beautifully summarized there. And the systems, it tells you that all of these symptoms can be involved. Bone involvement is quite common, but not in our case. And usually you will see sclerosis at metadiaphysis of long bones, femora and tibia. Retroperitoneum, now this is our case. And if you see here, there will be soft tissue cuffing of the aorta, which was not seen in our case. And kidney, we call it hairy kidneys. It is almost pathognomic, right? Pathognomic. Please remember, IVC and ureters are usually not involved, which can be seen in retroperitoneal fibrosis. Inflammatory process can be seen, with enhancement at the apex of the orbits within the CNS, pituitary, stalk, etc., or dura, etc., can enhance. In the lung, you can see, lung cyst like, and you can also see interlobular septal thickening, etc. So these are the manifestations of this. These are few cases from Radiopedia. So this is one example from Radiopedia, quite unique. Please remember your thought process was good, lymphoma and any hematomas surrounding the kidneys, but subcapsular, but this one was different. But your thought process was good. On PET scan, it shows a bit of uptake. This is another case, by the way. And there is a lot of soft tissue around the aorta also. Look at this one, kidney here and lot of hairy. And here you are. On MR, you see this is the kidney and how it looks like. Quite a unique appearance. These are three different cases from Radiopedia, enhancing intraconal lesions. This is what happens in the bones, particularly long bones, metadiaphyseal sclerosis. This is meningeal enhancement in the brain. So let's go through the case. So now you understand that the eye see what the mind knows. This is an example. If you have never seen it, you will never diagnose it. If you have seen it, you will never miss it. So it becomes all very easy. Now, pertinent negatives, is the aorta involved? In our case, it is not. IVC, ureters, they are not involved. Let's look at the manifestations, possible manifestations in the visualized lungs, and maybe you can see, you see these cysts here. So this is one of the manifestations which you can see, and then some septal thickening, non-specific, but one can say that it is there. Now, if you go to the bone window and try to see for anything in the femora, we don't see any other stigmata of this. However, the finding as far as kidneys are concerned, it's pathognomic. You cannot confuse it with anything. It's an aunt mini. So Erdheim-Chester disease. But you did well in your description and your approach. So I'm happy the way you tackled it. Okay, now candidate 4.
Yes, sir.
So this is 21-year-old female. Dysarthria 1 day CVA question mark, encephalitis question mark.
Okay, sir. I'm requesting controls.
Yeah.
Okay. I'm provided with the axial sections of T2 weighted images. A flare sequence. I'm sorry, this is a flare sequence. On the first scroll, I can see that there is a large area of hyperintensity seen involving the left temporoparietal convexity. This lesion, this altered significant area is causing mild edematous changes in the adjacent brain parenchyma with the effacement of the left lateral ventricle, and also is causing effacement of the lateral horn of the temporal horn. Okay. So I'm trying to assess what it could be. On the flare hyperintensity, this could indicate that localized edema in this patient, or a gliosis, or this could also be acute hemorrhage as well. So I would like to correlate with the other sequences.
Which sequence do you want to see?
I would like to look at T2 images and diffusion images.
So this is the diffusion scan. I'm scrolling it for you because of the time factor.
Okay.
So
on the axial sections of diffusion weighted image, I can see that the lesion is showing in diffusion restriction areas, and there are areas of non-diffusion restriction as well. The diffusion restriction is restricted. I mean, it is more towards the periphery. So this could be.
Let me show you a T2. You wanted a T2,
okay.
So this is a T2.
Okay, sir. I can see that there is significant edema involving the right temporal region, extending, involving both cortical as well as subcortical areas. So in a 21-year-old with dysarthria, I would be thinking in terms of infection as my primary concern. I would like to correlate with history of any seizure and any fever in this patient. That would explain if this could be a herpes simplex encephalitis. I would also, okay, there was no involvement of any basal ganglia, so that that is more likely, okay, suggestive of herpes simplex encephalitis.
Any other sequence you want to see?
The post contrast is available.
Post contrast.
Yes.
This is the post contrast.
Okay. On post contrast sequence, coronal sequence, I can see there is no evidence of any enhancement in the parenchyma. There is subtle enhancement involving the meninges. Okay. I don't see any intraparenchymal enhancement. So that rules out any lesion.
Any other things you want to see?
Okay, I would like to look at T1 images.
T1.
Yes.
This is the T1.
Okay, on T1 axial images, it shows heterogeneous intensity with areas of isodensity as well as hyperintensity as well as hyperintensity. So this could also be a lesion involving the left temporal area.
Give me your conclusion.
Okay, so this could be either lesion involving the temporal lobe, that could be DNET tumor, that will be my concern. With the history of fever and seizures, I would also keep a differential of herpes simplex virus encephalitis. I would like to correlate with the patient's CSF analysis, clinical history of seizures, and patient needs neurological MDT discussion for further management.
Okay, thank you. This was a case of venous infarction due to acute venous sinus thrombosis. Just a recap, we have got a superior sagittal sinus. This is the inferior sagittal sinus. These two are internal cerebral veins, the vein of Galen. They combine with the inferior sagittal sinus to to form the straight sinus. So the superior sagittal sinus is coming here. The straight sinus, this is the confluence of sinus, and then the transverse sinuses, right and left. And these are the two transverse sinuses. Of course, cavernous sinus is slightly different territory. And here, just to make a point that the internal cerebral veins, both of them are draining, and the vein of Galen, and then the straight sinus. This is an axial post-contrast sequence with internal cerebral veins, which are seen here. I'm showing you a few presentations of dural venous sinus thrombosis, which can come in the exam. And they will show you slightly tricky manifestations, but you have to develop your eyes on that. This is one of the favorites in the exam. Sometimes what happens is that dural venous sinus thrombosis can be seen on a non-enhanced CT as in a thrombosed vessel, just like a thrombosed artery can be seen in cases of stroke, like MCA, hyperdense MCA sign, or hyperdense basilar artery sign. So in this particular case, we can see that the internal cerebral veins, they are hyperdense, and the straight sinus is hyperdense, and this is the confluence of sinus, which is hyperdense. So this was a case of dural sinus thrombosis. Look at this case. This patient presented with clinically stroke, and you can see hemorrhage. Whenever you see hemorrhage, think about a venous infarction. In this case, there was a bit of hemorrhage around the transverse sinus, some high density at the vertex, and on a sagittal here. And the key finding here on the coronal, you can see that the superior sagittal sinus is high density and some of the cortical veins are high density. When we give contrast, you can see that this is the superior sagittal sinus, and you can see it is not enhancing, it is completely thrombosed. And this is what we call empty delta sign. CT venogram is a very good study, maybe better than an MRV, and you should ask it. If a CT is provided to you, ask for a CT venogram. This is another example where, this is the same case in which after 14 hours presented with multiple further hemorrhages. Another case of empty delta sign, venous sinus thrombosis. This is MR, a classical case, easy case, where we can see that the transverse sinus has got high density, as in blood. You can see it on this sagittal or parasagittal also, and you can see it as a filling defect on this post-contrast. And filling defect on this post-contrast. Key point to remember, it's not a must to go for an MRV study. You can diagnose as venous sinus thrombosis on your usual sequences or usual post-contrast sequences. Of course, in this case, these were some MRV sequences which showed the same thing. Coming back to the case, let's go through the learning points in this case. Now, first of all, please remember that as an examiner, I was guided by yourself. Whatever you wanted to see, I showed you. And one of the key things which you never asked was this thing. which was the SWI sequence, but I will come back to this. This is the flare sequence in which there is some high signal, and one can argue that what is happening, there are two different signal intensity on this flare sequence. Then you asked for a diffusion weighted sequence, and on diffusion you did very well, where you said that the central areas are not showing restricted diffusion and the rest of them are showing restricted diffusion. Here again, your mind should have gone into this. Is there some hemorrhage there? Now I showed you a T2, and on this T2 again, you can see this, slightly low signal, subacute acute hemorrhage will be low signal on T2 weighted sequence. And it was, because it was acute hemorrhage, it did not show any signal on the post-contrast sequence. On the post-contrast sequence, it did not show high signal. But if you look carefully on the coronal T2 weighted sequence, there was more to it. Now, if you see it here you are. This is when you see a coronal flare or a coronal T2 weighted sequence, this should be your protocol, by the way. It's what I call a poor man's angiogram. Sorry, a venogram. Look at the signal void of the superior sagittal sinus. Just look where my mouse is. Keep it goes back. And then this superior sagittal sinus goes to the confluence of sinus. And this is the transverse sinus on that side. What is the signal here? It's not black, it's gray. Something is happening. Now look at this and look at this. And with that comes this edema. Look at this. Actually, you can pick up that something is happening here. It should have been a signal void. It should have been black. It is not black. And with that, so this is the type of finding you have to pick up. And by the way, you did not ask for SWI, but on SWI, as I showed you, there was a lot of hemorrhage inside. And then on this one, again, you can see this filling defect. You see this is the sinus. This is the sinus on the right side. Either it will be a filling defect or it will be flow. Here you can see that there is something is clotted inside. But the T2 was very impressive. Of course, I did not show you sagittal, but on a sagittal also you can pick up this. This is the normal side and this is the abnormal side. You can see this filling, just like that delta sign. All of this is, you can pick it up. So you have to remember that dural sinus thrombosis is a very important exam case, but they will show you presentation which is slightly atypical. Basically, in venous infarction, what is happening? What is happening that venous outflow is, there is no venous outflow. So there is congestion. Because of this congestion, there is ischemia. Blood, new blood from the arteries cannot come in. And because of that, the endothelial lining of the veins, that will necrose, it will break away, and that is why there will be hemorrhage. So classically, whenever you see hemorrhage, and particularly it will be cortical and it will not be confined to a vascular as in arterial territory. Think about venous sinus thrombosis. Okay, well done. Candidate, this was candidate 4, correct? So thank you, candidate 4. Candidate 5.
Thank you, sir.
Candidate 5. Let me see if candidate 5 is with us or not. Yes, candidate 5. I'll make candidate 5 a co-host. Candidate 5.
Yes, sir.
Okay, so candidate 5, this is your case. And let me, this is a 29-year-old female stroke, clinically stroke, left-sided weakness. So they have done the stroke team has asked for this scan, A&E scan. Over to you.
Okay, sir. I'll just request for the mouse.
Mouse is with you. Not working. Try to hold that red. This. There is a red bar on top. Hold it and try to scroll through that. Let's see if it works. Otherwise, I'll scroll for you.
I'm trying.
Yeah, it does work.
It's not working smoothly, sir, at my end.
Okay, let me then take over. You don't move your mouse.
Okay, sir.
Now I am going to the vertex, and from the vertex I am so the first pass is done. Can you start talking now?
Yeah, I can. I've been provided with a non-contrast CT axial sections of the brain of this female patient who has presented with some stroke-like symptoms, and I can see that there is a hypodense area in the right temporal lobe, and there is there's no evidence. There's no evidence of any hyperdense focus, which I can see to suggest bleed in that region. Besides that, there is mild sulcal effacement, which could be due to slight edema. But rest of the brain, I can't see anything besides this right temporal lobe hypodensity. I would like to proceed this further with contrast enhanced imaging if they're available.
So what is your suspicion here?
Primarily on first look on the plane sections, I believe it's more like edema because there's some hyperdensity in the central portion of it in certain sections which I can see. So it looks like edema only in the first look. Yeah. So these are the contrast images, and here what I can see in those regions. Yeah, a bit lower now. Yeah. So here I can see that there is some gyriform kind of enhancement in that affected area, and which is surrounded by edema. Again in these coronal sections. Yeah, I can again see these similar findings. So there's some gyriform kind of enhancement which I can see in these coronal sections as well in that area. Besides that, I don't see any other significant finding. Yeah.
So till now, what do you think is happening?
In a patient where I'm suspecting gyriform kind of enhancement, I would like to inquire regarding history of any fever from the patient, because
no fever.
Okay, so because the differentials for this gyriform kind of enhancement includes encephalitis or some subacute infarct. So I would like to know the duration also, if possible, of the patient's symptoms, because there can be some infarct with some gyriform enhancement. So if it's in subacute stage, it can be because of
the symptoms actually on, though the patient presented in A&E, but these symptoms were going on for 5-6 days actually.
Okay, so it can be because of some subacute infarct, which is showing some gyriform enhancement.
What will you like to do next?
I'd like to proceed with MRI.
Okay.
Yeah, so these are the flare axial images of the same patient, and here again I can see that there is there is flare hyperintense area in the affected region.
Excuse me, this is
Yeah.
flare. I'll show you flare. I was
Okay.
showing you a DWI.
Okay, sorry. So these are the flare images.
This is the
Yeah.
ADC,
Okay, there's marked
and
restriction.
and right. So till now, what is your conclusion?
I'm thinking on the lines of subacute infarct, or it can be so much of restriction.
Right. So I have now given you a flare sequence.
So here I can also see that there is that there is flare hyperintensity beyond the margins which I saw on the CT scan. So it is a little more widespread, and there's some gyral swelling as well in the adjoining regions. So, but as there is no history of fever, I'm not thinking on the lines of cerebritis.
Right.
Yeah.
I'll show you a T2.
Okay. It looks more like following a gyriform pattern.
So what is your conclusion? Give me your conclusion.
I believe it to be it could be a neoplasm as well, low grade neoplasm, like
right.
Besides subacute infarct, which I thought initially. So these are the possibilities which are coming to my mind right now.
Okay, thank you. Cortical infarction due to venous infarction due to cortical vein thrombosis. Now, please remember the anatomy. Now, even when I was showing you a dural sinus thrombosis, I showed you some cortical veins which drain into the dural sinus. So it all depends on anatomy. Now, look at these veins. Now, this is the transverse sinus. This is the superior sagittal sinus. There are too many variations, so nobody labels them on any scan. But just to give you an idea, that this vein here is known as vein of Prollard, superior anastomotic vein. Superior anastomotic vein. This one here is vein of Labbe, inferior anastomotic vein. This one is superficial middle cerebral vein. So don't think that you will see them like this in each and every case, but there will be variations. Now, this is from a superior view, where this is, these are the veins of Prollard. So sometimes what happens is that, particularly if the sinuses, please remember the transverse sinus is hypoplastic, and hypoplastic, then these superficial veins will be very prominent and their role will be more important. So you will see cases in which there will be cortical infarction because of superficial vein thrombosis. So this is how a vein goes into the cortex, and this is how the artery goes, and this is the connection. I have also already told you that when there will be venous thrombosis, then this arterial blood cannot go in, and then the endothelial lining of the vein will be damaged, and that is why there will be most commonly there will be hemorrhage, but there will be cases in which there will be no hemorrhage. and then the cortex is involved. So this is a case of dural sinus thrombosis with cortical vein thrombosis. Just to make a point, from my collection, I am showing you that on a non-enhanced CT, you can see that the dural sinus, superior sagittal sinus, is thrombosed, right? Now, this is a non-enhanced CT. Now, if you look carefully, look at the superior sagittal sinus. It is now, what is this? Where I'm pointing out. Where I'm pointing out, there is a superficial vein which is thrombosed. And here, there is another vein which is thrombosed on the left side. And this is, again, thrombosed. And you will see the effects of this on an MR. And this patient, by the way, presented with stroke-like symptoms. And so this is the superior sagittal sinus. And some of these veins where I'm pointing out, these are thrombosed. So we did an MR. Initially a CT venogram. On CT venogram, you can see this filling defect in superior sagittal sinus. You can see this filling defect in superior sagittal sinus. On MR, you can see this some high signal where the sinus thrombosis is. You can see loss of signal void on this flare. But the key finding is this one. You see this? This is a small acute infarction. And you can now imagine that there must be a vein which is draining this portion into the superior sagittal sinus, and because of that, there is an infarction. So, coming back to the case, now, this case was about 5-6 days old. There can be enhancement even in stroke after maybe 5 days. There can be leptomeningeal gyriform enhancement that will not change anything. This was the initial non-enhanced. And the key finding is that it does not correlate with any arterial territory. And then on post-contrast, there is a bit of gyriform enhancement, which is explainable. And then on this MR, the key finding was restricted diffusion. It was very impressive. Look at the restricted diffusion. Now, try to concentrate here because this is the restricted diffusion. And please remember on ADC, it was also low on ADC. But the but is that you don't see anything more here in this region. You see this thing here. And actually, this is a thrombosed cortical vein, this one. This one is a thrombosed cortical vein, which is, this is it. And in this case, we did venograms, etc., which I am not showing you right now. The right-sided transverse sinus was hypoplastic. So the hypothesis is that this cortical vein was quite prominent and it was thrombosed, and because of that, there was a venous infarction. So I just wanted to show you that cortical, venous infarctions can also be due to sagittal, the sinus thrombosis or cortical vein thrombosis, and sometimes just because of cortical vein thrombosis, as I have showed you. Okay, candidate 5. This is your last case. Over to you. 90-year-old. So, acute abdomen. Over to you. A&E fail. Candidate 5. Let me check candidate 5 are there. I think we have lost candidate 5. Candidate 4, are you with us?
Yes, sir, I'm here.
Okay, if you want to tackle it. A&E fail,
Okay, sir.
acute abdomen, 90-year-old.
Okay. I'm presented with the frontal abdominal radiograph of a 90-year-old male who presented with abdominal pain. On the first glance, I can see that there are multiple dilated bowel loops. I'm trying to look for any free air. I don't see any obvious air under the diaphragm. I can see both walls of the bowel loops in the left para lumbar region. However, I would like to confirm an orthogonal waves or any CT scan. But I'm trying to look for cause of the dilated bowel loops. Okay. I don't see any obvious hyperdensity which would suggest gallstone alias. I don't see any obvious lesion. I'm trying to trace the palato-sacroiliac joints. However, I can't see it properly on this view. That I was trying to look for any inflammatory bowel disease which could cause this intestinal obstruction. Other than that, I don't see any cause for this obstruction. I'm trying to trace these bowel loops below the pubic bones to look for any hernia. On the left side, it is suspicion of there is a suspicion of hernia. However, I'm not very sure. So I would like to convey my findings to the clinician and request urgent CECT abdomen and thorax
Okay,
to look for transition point.
Which bowel loop is this? What is this?
Okay, so I think this is a transverse colon with the loss of frustrations, and some of it also shows a thumbprinting sign.
Okay. So what is,
So,
as far as this film is concerned?
Okay, so that would be concerning for inflammatory bowel disease. So that would explain the lead pipe appearance of this transverse colon. So I would like to correlate with the history of the patient, any previous images if available in this patient.
Any other
I would
finding
also,
other than the bowel? Any other finding you see on this film?
other than bowel, I'm trying to look for bones. I'm trying to, okay, the left hip joints shows significant sclerosis and loss of joint space, and there are areas of lucencies and sclerosis. So that would be either, okay, explain degenerative changes or avascular necrosis in all the left hip joint, secondary to maybe with because of immunosuppression, which steroids, which complicates hip AVN in this patient. I would like to correlate with history. However, I don't see any hip, I'm sorry, any steroid depository in the rectal region. I would like to.
Okay, now because of time factor, I'm going to show you the axial of the CT scan of this patient. Okay. I'm going up. Disregard the liver, etc., and the pancreas. I'm not interested there. There are findings there which are chronic. Don't worry about it. Just concentrate on the gut.
Okay. So these are the axial sections of post-contrast images. You can see that in the left. Okay. The entire ascending colon, transverse colon, and descending colon shows significant neural wall thickening with adjacent fat stranding. There is herniation on the left side as well as on the right side. On the right side, the bowels are reaching up to the testis. There is also evidence of free fluid.
Okay,
you're free fluid in the hernial side. Okay, so this is a pantaloons hernia which is causing uh, obstruction, and associated with that, there is a inflammatory bowel disease involving entire colon, so that would make it as ulcerative colitis. So I would like to convey these findings to the referring clinician. The bilateral SI joints appear normal. The left hip shows a significant sclerosis, and the contour of the head of femur is maintained. So, there is also significant sclerosis involving the iliac bone.
So conclusion.
So, ulcerative colitis with the pantaloons hernia involving both inguinal regions, and maybe secondary sclerotic metastasis complicating or could be associated entirely Paget's disease of the left iliac bone, entirely independent.
Thank you. So this was a case of toxic megacolon, bilateral non-obstructive inguinal hernia, and Paget's disease. Busy scan, there was an acute finding, and there were some findings for observations. So in toxic megacolon, you have to look for, so this is normal hostra in a normal colon, and you can see that there is loss of hostra. Second thing is thumbprint, which is this and this and this. And in some cases, you will see pseudopolyps which are projecting into the lumen. So these three things you have to remember. These are two other cases of toxic megacolon. Toxic megacolon is very important. Even it comes in rapid reporting. Remember that. It comes in the VIVA, it comes in the rapid reporting, and you can see these thumbprints, you can see these pseudopolyps, you can see loss of hostra. This is another one, loss of hostra. And so always remember any gut bowel loop which is going across the midline, transverse colon, look for it. In your book, megacolon is two different headings, subheadings, non-toxic and toxic, where there are severe mural abnormalities, and which includes IBD, UC, Crohn's disease, infectious colitis, ischemic colitis. And this is a case in which thumbprinting can be seen actually in the descending colon. And this is the differential diagnosis of thumbprinting in colon, which can include ulcerative, Crohn's, ischemic, pseudomembranous amoebic schistosomiasis, and sometimes it can also be seen in lymphoma and metastasis. Now, let's go back to the case. Now, this was a plain film, and on this plain film, the candidate did well, where was thinking about hernia. So, by the way, you can see that there is hernia, and I wanted the candidate to pick it up, which the candidate did pick it up, but the main finding was actually visible here, and this was a toxic megacolon. And then this is Paget's disease. There is absolutely nothing wrong as far as avascular necrosis is concerned. All of this is coarse trabecular pattern. All of these bones, pubic, ilium, ischium, this iliac wing, everything is coarse and classical for Paget's disease. Same finding on the CT scan, where we can see so as far as the colon is concerned, we can see a picture of sort of pancolitis, where and this is the fragment, the segment which was visible on the plain film. It is slightly 1 day delayed film, so it is not same gas pattern, and then it goes into the hernia. I did not have time to show the hernia in detail to the candidate, so don't worry about it. You did well, but having said that, it was not causing obstruction. Similarly, the right hernia was also not causing obstruction, but the idea was to pick them up, particularly on the plain film. And pertinent negatives was that there was no sacroiliitis, but look at the Paget's disease. It's classical Paget's disease. So case of multiple findings. Well done, candidate. Next candidate is last candidate of the day. Candidate 6, are you with us?
Yes, I'm there.
Okay, so this is a case of 24-year-old patient presented with polyuria. They have said hypothalamic dysfunction, question mark, polyuria. They have asked for MR of the pituitary. Over to you.
Okay. I'm presented with sagittal sections of T1 weighted brain. Can I request for the remote?
Yeah.
Okay. I'm trying to scroll. I can see that I'm looking at the brain parenchyma if there is any obvious abnormality, and then going to go to the midline to see the pituitary in this patient who presented with polyuria. The pituitary, within the pituitary fossa appears normal in this sequence. The pituitary stalk is normal. There is a hypointense area in the posterior portion of the pituitary, which could be adenoma. I would like to correlate it even on the coronal sequence. Yes, even in this cut, I can see that there is a hypodensity noted within the pituitary. So I'm thinking it could be a pituitary adenoma or a Rathke's
Just 1
cleft.
second, please. Just 1 second, please. Or a Rathke's cleft cyst. So
Yes.
I will show you. Just don't use your mouse. I'm using the mouse. This is the appearance on coronal, and because of time factor, I will also show you a T2 weighted sequence.
Okay.
I will again show you the post contrast. You are right that there is something there, but it is
Rest of the pituitary is showing normal enhancement in post-contrast sequence. Just that one small foci is showing non-enhancement. On the T2 weighted sequence,
yeah.
I'm not able to appreciate any abnormality on the T2 weighted sequence. There is I'm trying to look at the stalk for any abnormality, pituitary stalk, but that appears to be unremarkable. So in a hypoenhancing focus in the pituitary, my top two differential would be a Rathke's cleft cyst and a adenoma, pituitary micro
The
adenoma.
patient presented with polyuria. Can you explain the symptoms with this finding?
No. No, I would not be able to do that with anterior pituitary mass lesion. So there is also enhancement of the pituitary stalk.
What would you, anything else you would like to see? Any other symptoms?
I would like to look at the posterior pituitary bright spot if it is present in the non-contrast T1 weighted image. So I'm not able to appreciate the posterior pituitary bright spot in the set of images. So I'm also looking at the axis to look for any ectopic position of the posterior pituitary bright spot, which I'm not able to appreciate. So this could be absence of a posterior pituitary causing these polyuria like symptoms. I would convey these findings to the referring team and request a neurological evaluation for this patient. Thank you.
So the posterior pituitary is absent. Why is high signal seen in posterior pituitary normally?
Because of the granules, posterior pituitary granules, which are giving
Granules
back
of
to
what?
I'm forgetting the name.
Okay. So what is your final conclusion?
This is a posterior pituitary oogenesis with a possibility of a pituitary adenoma or a Rathke's cleft cyst in the anterior pituitary.
Okay. This is diabetes insipidus with loss of normal posterior pituitary bright spot. So a few concepts. This is from Radiopedia, so you can read it from Radiopedia. The posterior pituitary is also known as neurohypophysis. It is, please remember, it is a direct extension from the hypothalamus. So it is CNS or central nervous tissue connected to it via the infundibular stalk, which is also considered part of the neurohypophysis. Two hormones there, which are produced, oxytocin and antidiuretic hormones, are sensitized in the hypothalamus. Remember, they are sensitized in the hypothalamus, and then they travel down the stalk to be released in posterior pituitary. So they are stored in the posterior pituitary. So this is it: hypothalamus, pituitary stalk, and posterior pituitary. You know, this structure here is a pars intermedia, and the finding which we saw as a filling defect in our case, though on a T2 weighted sequence, it could not be picked up. It can even be a pars intermedia cyst. Cysts in the pituitary are very, very common, and microcysts are so common at times you don't see them on other sequences. In postmortem studies, up to 22% people have got cyst in the pituitary. In any case, coming back to this posterior pituitary, so that is stored here. The ADH is stored here. And this is the concept again from Radiopedia. Posterior pituitary broad spot is an MR feature of normal pituitary gland. It refers to intrinsic high T1 signal in posterior pituitary thought to be due to storage of vasopressin, which has got a T1 shortening effect, just like hemorrhage or methemoglobin. So what is diabetes insipidus? And it is, in this case, there can be deficiency or resistance to vasopressin, which is the ADH or antidiuretic hormone, which results in what? Polyuria and polydipsia. There are two types. One is central and second one is peripheral. Role of imaging is to rule out central cause of diabetes insipidus. And so in this case, the vasopressin is deficient. But the peripheral one is by exclusion. We can reach that conclusion. These are the causes of etiology-wise: central causes, peripheral causes. Trauma, neurosurgery, or if because of some region there is destruction of the pituitary, may it be tumor or neurosurgery, trauma, etc. Of course, it can be this. But autoimmune conditions, IgG4 related disease, etc., infection, pregnancy, idiopathic is another one. Key point is, exam point is, look for the bright spot. If the bright spot is absent, look for some other etiology. So always ask for, key exam point is, ask for pre-contrast T1 weighted sequence. Otherwise, you are not going to reach that diagnosis. This is a case, if you see here, look at it, IgG4 related disease. I don't have time to teach you IgG4 related disease, but there is infundibular thickening here. You see this thickening? And where on T1 weighted sequence, where is the bright spot? So the bright spot is lost. Don't confuse it. This is fat in the clivus, in the posterior clinoid process, sorry. So this is fat in the bone. There is no bright spot here. And here the cause is IgG4 related disease or hypophysitis. So this is what this case was about. Well done, candidate 6. Your last case of the day is just an observation case, easy case. And let me give you a bit of history. Okay, listen to the history carefully. 79-year-old male. Patient is a known case of prostate CA under treatment and known to have bone metastasis. Patient is getting medical treatment. Now, what happened was that the patient developed abnormal blood culture with signs of infection. They did a urine culture, which was normal. So there is infection going on. Microbiologists have advised imaging. They want us to tell them what is the source of infection. Over to you. You have to tell the source of infection to the microbiologist. Over to you.
Okay, I will request for the remote.
Yeah.
So these are actual post-contrast sequence of the abdomen of a known case of a prostate cancer on treatment with bony metastasis. Looking for the source of infection as prescribed. The liver appears normal. There are no evidence of any liver abscess. The spleen shows no collection or any focal lesion. I'm looking at the kidneys and the bowel loops now. They are a bit shrunken in size with perinephric fat, but that would be expected in this age. Looking at the mesenteric fat. Okay. There is an appendix visualized in the right iliac fossa, which appears normal. Okay. I can see some abnormality in the adjacent to the bowel loops in the periumbilical region. I'm trying to see if it is a distended bowel loop or is it a collection. Okay. I think there is a peripherally enhancing area of collection noted within the mesentery, which is adjacent to the sigmoid colon. And it also has multiple air foci and adjacent fat stranding. There is evidence of a few diverticuli in the adjacent segment of the colon. So I'm thinking that this could be a complicated diverticulitis with perforation and diverticular abscess formation. So I would urgently inform my findings to the referring team regarding this being the source of infection and refer this patient to the surgical team for appropriate management for the patient, and this patient would also need to be on an antibiotic cover. Thank you.
Anything else?
Okay. Looking at the pelvic sections. The urinary bladder appears normal. Rest of the bowel loops are collapsed. Okay, trying to see if there is any other abnormality within the bowel loops or any other collections. I'm not able to see any. Okay. I'll just scroll through the set once again, focusing on the pelvis.
Hint, look at, you must be having a protocol for your abdominal CT. So you are looking at the soft tissue. Anything else you want to see?
I would also look at the bony windows.
So look
to
at the
see.
bone, please.
Okay.
On this window, look at the bone.
Okay. There is osteopenia that I can see in the first instance. Trying to look for any areas of destruction or lysis. I can see that there is some lytic changes noted within the vertebra at this level with perivertebral soft tissue. As this is a known case of metastasis, it could be secondary to the prostatic metastasis. I would also correlate the findings on a bone window on a sagittal and coronal reformatted sections.
Just 1 second, please.
Yes.
Which window do you want to see?
Bone window.
Okay. I've given you bone window. Yeah.
Yeah, I'm trying to scroll. It's a bit lagging on my end. Yes, there is sclerotic, lytic sclerotic changes noted in the L3 vertebra with partial collapse of that vertebra. The hip bones appear normal.
I've given you once again bone window. Sorry, soft tissue window.
Okay.
Okay, madam. Now give me the conclusion.
So I'm thinking this is a case of complicated diverticulitis with
Thank you.
abscess and metastasis.
Right. Thank you. So this was a case of, this is a classical case of satisfaction of search. Satisfaction of search, you picked up diverticular abscess. There was spondylodiscitis with Swas abscess. And there was spinal and pelvic bone metastasis L3 pathological fracture. But this is the main finding, because for that, the treatment or the regime of the antibiotics will change. And that is the key finding, which, classical learning points in this case is satisfaction of search. Don't stop, keep looking, your bone window, your this, your that, everything. Now, first of all, in UK, the way radiology, infection is practiced, microbiologists are very active and they ask for these kinds of scan very, very often. And at times we do a whole MR of the whole neck, etc., etc. So it happens, and that's, I think, very professional. They lead this, can you tell us a source of infection? Now, somehow the other on my screen, something is projecting, but in any case, this was the abscess. This is the abscess. The loop of bowel is next to it. So this is a diverticular abscess. Now, if you see this window, look at this. You can see it actually. Look at this. This is the Swas, right Swas, left Swas. And actually, you can see a Swas abscess here. It is enhancing. And then it is even air bubble is visible here. And 2 air bubbles are visible. 3 air bubbles are visible. And then you see this destruction. Actually, there was a fracture, which is a pathological fracture, secondary to the metastasis. and secondary infection. So now, just to make a point, this was also a old fracture with metastasis. And then here you are. This is that area where you can see fractures. I've shown you the soft tissue abscess. So in the exam, if I want to give you as a long case, I will just give you axial. Otherwise, if you've got the luxury to see everything, you can see this fracture lines. So this was the fracture. And of course, on a coronal also, you will be able to see, here you are. You see this enhancement. This is the Schwarz abscess. And here it becomes even better. And the bubbles which I was showing you. So this was a satisfaction of search case. Thank you very much, candidate 6. Well done. You did well.